Hello, and welcome to My World of Medicine. I'm Dr. Russell Libby, and I'm happy you could join me. You know, on the show, we learn about important medical conditions and other topics through the experiences and insights of people who have lived through these kinds of problems. Our studio audience is going to help you understand some very important issues tonight. In particular, we're going to talk about some neurologic problems that people experience, and quite commonly. Many of us don't really understand things like Parkinson's disease, essential tremors, things that affect our mobility and a lot of our functions until either it strikes us or it strikes a family member, and then we learn very quickly. They're very important issues. Parkinson's disease probably affects over 500,000 people in our nation. There are probably another 500,000 who don't even know that they have early symptoms. So it's important for you to learn, and that's what we're here to do. So I want to thank the studio audience for taking their time to come here to help with this show. We have with us a very well-respected and highly appreciated neurologist, Dr. Linda Sigmund. She is a national specialist and expert on Parkinson's disease and other movement disorders. I want to thank you for coming to be with us so we can have your expertise to help complement all of the expertise we're going to get from our folks here in the audience. Movement disorders, like I said, Parkinson's disease, essential tremor, even something like restless leg syndrome is something that is actually in that whole group. That's one that many people probably hear about on television, something that can wake you up and make you pretty miserable, but somewhere between 5 and 10% of people over the age of 50 might have that. So stay with us. I want you to hear about the things that these people have experienced and understand them as well. Now, essentially, people would wonder, at what point do you start to have symptoms? And I wonder if anybody here can sort of go back and sort of remember some of the things that may have happened early in the course of their illness. Anybody? I'd love to have you talk to us and sort of give us that insight.
Well, I started out with tremor, and I learned to hide it. I learned not to hold papers and to stand like this with my hands under my arms so they wouldn't shake. And then I went to a normal doctor, and I said I have low blood sugar because that runs in the family. But my sugar number was perfect. So she said, if you want, here's a hypoglycemic diet. And I said, okay.
So that was a pretty good way to start.
But in January of the next year, I joined an HMO, Kaiser Permanente, and I got diagnosed that way by having a physical.
Okay, so you started off with just what was an essential shaking of your hand. Can you show us what that was like?
What I started out with was 10 years before I went walking with my parents, who hated me not moving my arms when I walked.
So it was something else that you noticed that basically took a long time to evolve.
Yeah, 10 years.
Okay, well that's interesting. And the gentleman up front here, you had some experience there. What were your early symptoms?
Well, mine are more cut and dried. Yeah. About 15 years ago, I was in Japan with the Foreign Service, and my hobby was scuba diving. I loved the water. And the boats were too expensive, so we would climb down a cliff, go in, swim, do our dive, come back up. And after a while, I discovered that, it was lowered on me like a ton of bricks, that I still had the strength and the coordination to go up and down those cliffs with my gear, but I couldn't quite put it all together to do that. I'd have to strip off my gear at the base of the cliff, go up, so I'd catch my breath, go down and carry the tanks up, the dive tanks. Then we came back to the States, and I wasn't climbing up and down cliffs anymore. Then I went to an embassy in Europe, Embassy Athens, and I mean, it's probably the most verbal job you can have, right. Talking to people all day long, taking notes, interviews. After a while, I couldn't hold a pen anymore. Went to a major event, and my boss came in late, came in back and sat down beside me. And I saw this look of horror on his face. Oh my God, have we gone to war? Well, if you'd known the guy, maybe we almost did. But I looked down at my notebook, and it was just a little bit of gibberish. And from that day forward, I had to find other ways of recording or memorizing my thoughts. And when we came back here, I found that I could take the metro into the subway, Washington subway, into work, get off at the Washington end, and somewhere between the subway station and the State Department, which is about a 15-minute walk, my legs would give out on me. I'd have a spasm, foot spasm. Sometimes my leg would curl completely up like this. Sometimes it was subtler. I think I must have been in denial because I told myself, this is a delayed reaction from the Vietnam War. I've never served in Vietnam, but
right. Just thinking about it could do it.
I'd been in a training accident in which I was in a military vehicle accident, right. And I got a bad blow on the head. And my wife and I, between us, we convinced ourselves that this was a delayed reaction to
closed head trauma,
to a concussion.
Right.
Yeah, I didn't even have the jargon.
Right.
After a few years of this getting steadily worse, I finally admitted I needed to seek help. I took my son to Southern California to visit a college. We stopped to see my sister on the way. My sister is a healthcare professional. She took one look, listened, and she said, "You're crazy. You're going to see a doctor the day you get back."
Right.
So I did. Saw an internist and worked up the chain from there.
Yeah. So we have one person who had a tremor. And does anybody have a tremor that they can show us that is noticeable, that may be something that, well, here, we've got a good one right here. But yes, you have one?
Yes, I do. I have essential tremors.
Essential tremors, okay.
Mainly in the hands,
yep.
Some in the lip and tongue and voice.
Okay.
Okay. Through medication, they've gotten so much better.
Right.
But I did not seek to see a doctor about them until I was 49 years old.
So essential tremor, and that's something we'll get more, let's say, more deeply into later in the show, but that's something that can come on anywhere from adolescence and on.
Oh, I noticed it when I was in my teens.
Yes.
But my mother was epileptic.
Right.
My dad was diagnosed with shaken palsy. So
that might be what they called it back then.
Yeah, that's right. I'm sure of it. So I thought, I'm going to have to deal with it. Both parents have something like that, and so I'm going to have to deal with it. And it progressively got worse. And when I was 49, I finally went to my internist in North Carolina, who diagnosed essential tremors and put me on medication.
That's very interesting. So here it is, and I know that most people will talk to someone who has a tremulous voice, one that's a little weaker, has that sort of fluctuation, and they'll wonder what it is. And that's what it is.
That's what it is.
That's what it is.
Yeah.
And you have?
I have early onset Parkinson's.
Early onset Parkinson's.
Yes. My first symptoms were 17. I had a tremor in my left foot, and didn't know what was causing it. So I went to see a doctor. He said, over a period of 6 years, I saw over 9 different doctors. They all said, "You're too young to have Parkinson's disease." So I had an essential tremor. Have a beer, relax, chill out. It's just stress. And then, but not until I was 23, when I was on a camping trip. I was on Outward Bound. They said, "You're a health risk. We need to send you back early. Let's go see another doctor." By that time, it progressed to a point where they actually say you have Parkinson's disease.
So you were in Outward Bound, though. Those are generally pretty tough trips.
Was.
You were ready for something like that.
I thought I was.
And what happened there that disconcerted them or alerted them to what was going on?
I was struggling. I thought I'm prepared for 6 months, and I thought I was ready, but I was struggling, and we were carrying 50-pound packs on our backs, and going about 12 miles a day, and after 6 days, I just couldn't do much more.
So you were becoming exhausted.
Yes.
Which was understandable from the way you described that trip. So do you have a tremor now?
No, I don't.
No.
Luckily the meds are working for me.
Oh, that's great.
And
Okay.
after 23 years, the cinnamon still works for me, which is a miracle.
That is a miracle, and we're going to hear more about these medicines. So, Dr. Sigmund, tell us a little bit. Obviously, we've got two really interesting stories. One with an early onset of tremor that she pretty much denied for a long time, which means that it must take a long time for this disease to progress. And then one who had an essential tremor, who had a family. Her father had the same sort of thing, although they called it something different, and basically didn't have time to pay any attention to it in the first place. So tell us a little bit about what tremors are and how they look and what they represent.
Well, tremors can look very different in an essential tremor patient versus someone with Parkinson's disease. With Parkinson's disease, 80% of patients, that is their first symptom, and it's a resting tremor that they call a pill rolling tremor. And an essential tremor is more of an action tremor when you go to do something. So if you go to drink or if you go to eat, your hand tremors, whereas a Parkinson patient often has no trouble eating or drinking, yet when he's sitting still watching TV, their hand is gone like crazy. So those are the main differences. And usually the tremor early on doesn't really interfere very much with either the Parkinson patient or with the essential tremor patient. But as time goes on, essential tremor patients, they used to call it benign essential tremor, which is really a misnomer because it really isn't benign, because with time it can significantly interfere with activities of daily living. And with the Parkinson patient, although the tremor may not be troublesome, they develop slowness in movement, gait, walking instability, stoop posture, soft speech, and other more global problems that interfere significantly with their ability to perform activities of daily living or necessitating them changing their lifestyle.
And for you?
And I don't have a tremor now.
You don't have a tremor now?
No.
Yeah.
In fact, it's a symptom that I don't have.
Okay.
But I had deep brain stimulation. I wanted to see that.
Okay, well, and we're going to talk about that because that's a very important component of the treatment. And we're going to try to understand a little bit more about the evolution of symptoms. So we've talked about tremor. There are other kinds of symptoms that people experience, and one of the things we heard about here was that we have sort of a loss of coordination or balance, I guess is what you were really sort of describing, that carrying all that equipment made it difficult. You felt like you didn't have that kind of confidence in your body moving, and that was a very remarkable thing to experience.
Yeah, also very frightening.
Very frightening.
The fear and the denial came down like a blanket. And it took some years to force that blanket up.
Give us an idea of how many years you're talking about from when you look back and say, you know, that's when it started, as to when you were really diagnosed.
The first time I was unable to climb a cliff with my gear on, with the rest of the dive party, was
20 years ago.
Yeah.
20 years ago.
Right about that.
Okay.
And when I first got the leg curling spasm,
right,
which just polarizes, it knocks you flat right where you are, was. I can give you a year, 1996, 95, 96.
Okay.
And when
So that was about 10 years later?
And when I finally
had your diagnosis?
Yeah, that was March of 1998.
Okay.
And then the business with the hand with the writing,
yes.
To me that was the most horrifying physical evidence of all. That was the fall of 1992.
Yeah. So your handwriting became illegible, basically.
No, my handwriting ceased to exist.
So it ceased to exist altogether.
Yeah.
So if it's illegible, you can become a doctor. That's about it.
My last overseas embassy was Athens. I took a Greek language course. A lot of my note-taking was done in Greek. When you try to write something in Greek and you go back and it's illegible, you know you got a problem.
Well, it would have looked like Greek to me, I'm sure. I'm sure. But I do want to hear more. We've got a gentleman here who's certainly been through some of it.
Yes.
How did you first remember your symptoms beginning?
Being sense of smell, loss of sense of smell.
So that's where it started for you, was your sense of smell. And how did you recognize that that was what was going on?
Well, I worked in a office where I went for a diagnosis.
Right.
And the man said to me, "Don't even sit down, you have Parkinson's disease."
Is that right?
Yeah.
So that was because of your history, or?
Of just the findings.
Yes. Were you in any kind of business where you needed your sense of smell to be able to work, or?
Yes, I was a dentist.
You were a dentist. Yeah. And there is a lot to the sense of smell when you're dealing with your oral cavity. It's interesting. People probably don't think about it, but you learn a lot from that when you're working in that venue. So at what age was that you started to notice? Were you having tremors with your hands as well?
Yes.
So
resting tremor.
Resting tremors, okay. And so you were able to work for a while there?
Yes.
At what point, what age were you then when that happened?
40.
40.
About 40. So the onset of symptoms started at 40. And how did those evolve? So you had lost your sense of smell, you had a resting tremor.
Then he stopped using his right hand.
Stopped using his right
He
hand.
started then swinging his right arm.
Okay.
And then his foot started dragging. His right foot started dragging.
So
It was very gradual.
it was very gradual. Over what period of time?
7 or 8 years.
7 or 8 years.
But he was diagnosed at the age of 45.
At 45, okay. And you've been living with Parkinson's for how many years now?
Since 1980.
Since 1980. So you're aging well.
No,
That's good. And you're working with the disease, and you are finding ways to inspire yourself to keep going with it. I know it's taken. Well, at what time when did you stop practicing dentistry?
Well, I had a break because I trained also as an epidemiologist.
Oh, okay. So you were able to turn to something else that you had some expertise in. That's good. So you stopped there as soon after you had that diagnosis.
Yes.
Yeah. Okay. So we've had some of the evolution of symptoms described that people have experienced. Anybody else lose their sense of smell or any of the other senses that they valued and treasured?
Yes, I lost my sense of smell, I don't know, probably 30 or 40 years ago. I did not particularly notice it at the time, and certainly did not associate it with Parkinson's. But after I was diagnosed and read up on it and so forth, I said, oh, yeah, that's what happened there. The first symptom I got was tremor that I recognized as being a problem. And my father had essential tremors, so my internist assumed that's what it was. And she said, oh, you don't have Parkinson's. But I saw a neurologist, and he said, well, I can't be sure you don't have Parkinson's. And then over the, I don't know, maybe 4 or 5 years, it evolved into a pretty textbook case. The slow movement, the gait, balance problems, small handwriting. You know, it was just, as I said, a textbook case. And then my neurologist said, well, you know, this looks like what it is, and started me on medication. When I responded to the Parkinson's meds, that was sort of the clincher.
Right. So that gave you at least gave you the confirmation,
Right.
Even though you knew so much by your virtue of your own research,
Right.
and you're knowing your symptoms better than anyone, really.
Right.
So it was. It sounds like it's a very tough thing to sort of accept and understand. Hearing.
Actually, it's, in a way, it was a relief when I sort of had a name to put on it.
Oh, is that right?
Yeah.
You knew you could do something about it.
Yeah.
You
yeah.
knew that there was something.
And I was taking
out
all
there.
these other meds for essential tremor that were not really working.
Right.
Yeah.
So you got to get the right diagnosis. Well, how many people did go through some misdiagnoses and had to suffer through some workups or other kinds of operative events or whatever?
I just wanted to say I went through a misdiagnosis, the low blood sugar, which is very typical.
Right.
But at the same time, when I started with Parkinson's, I had already been diagnosed. I was diagnosed March 25th, 1987. And then I was going to take a hike down the Grand Canyon with a 12-year-old. And I was 1,000 feet down, and I knew I chewed off more than I could chew. Yeah. And I started crying.
Did you get assistance to get out
And
then?
I got assistance to go all the way down and all the way back. I didn't meet any of the Parkies down there.
Yeah. I imagine you would. I would imagine. But it sounds like you've got a good club there. Yes.
I was misdiagnosed as having Parkinson's disease, and eventually it was diagnosed as palsy for me.
Okay. So it started with the tremor for you? Is that the first thing you
shaking
experienced?
Shaking of the hand, yes.
And everybody assumed, well, that's the most common diagnosis. That's probably what you have.
Most doctors said that that's what I had, and they were able to show me that I had Parkinson's disease.
Right. And how long ago was that? You remember?
Perhaps 4 to 5 years ago.
Okay.
And eventually I was diagnosed as having palsy and not Parkinson's disease. And it has affected my eyesight and my ability to speak.
You're doing very well.
Thank you.
And I imagine, and yours has progressed a lot more quickly than what you might see with a Parkinson's too, it sounds like.
Well, it hasn't progressed in the sense that it has affected my brain.
Right. But it's just difficult to talk all the time.
Yeah.
I understand that. So you were misdiagnosed, and I guess that's a question I want to ask Dr. Sigmund too, because it's very interesting to me. There are a lot of symptoms we're hearing that people experience, and they may experience it during that ripe period of their lives where it may be a confusing diagnosis. For instance, the shaking and saying, well, it may be low blood sugar. You may have felt better after you ate, or it may be just holding something and eating it that makes you stop being tremulous. Are there confusing symptoms that you think people may miss or may need to understand and better be aware of on their own body and their own being?
Well, it's not so much the patient's responsibility to make the diagnosis. It's really the physician's responsibility. And if you get there's a couple of things that we use to make a diagnosis. One, a very good history, as you know, how the symptoms evolved, and what kind of tremor it is. If there are any problems with gait or balance, then we pretty much know it's not essential tremor. If someone starts out and has early problems with balance and speech and inability to move their eyes, we think of progressive supranuclear palsy, and that's what this gentleman has. But early on, for even most general neurologists, and it's difficult to make a diagnosis of Parkinson's disease right at the onset, because everybody looks the same.
Right.
You can have a mild tremor or mild walking imbalance, and then after a year or so, you see how the symptoms evolve, and then it's easier to make a diagnosis. And even when you place patients on Parkinson medications, even Parkinson syndromes like progressive supranuclear palsy can initially respond to Parkinson medications, but over time, their response diminishes significantly. Where with a Parkinson patient, as you see from some of the patients in the audience, they continue to derive benefit from their medications over many, many years.
And another thing that we've been hearing is that the evaluation sometimes can be confusing, which means that it's not a single lab test, it's not a single X-ray, there's no litmus test for this. I guess having I guess, an instinct or an intuition that something is a little bit more wrong and seeming to change is one thing, but are there any studies or scans or other things you can do to diagnose the different types of tremors?
Basically, what you do when you're seeing a patient with essential tremor or Parkinson's is that you're looking to make certain that there's no structural abnormality found that would account for the symptoms.
So you will do like
So
an
it's more of an
MRI?
exclusion criteria.
Right.
Yeah, so you do an MRI scan, make certain that there's no brain tumor or normal pressure hydrocephalus or stroke in the area of the part of the brain that can cause Parkinson's. And once you rule out the structural abnormalities and you've looked at the medications and made sure that there are no medications that could cause Parkinson's symptoms, which there are many around, and then it's really a diagnosis of exclusion. You make certain that there aren't any secondary causes, and then you can make a diagnosis. But you don't see very often typical findings, particularly in early MRI scans.
Okay. There are a whole list of different types of symptoms that people experience. And I go back to you because your speech suggests that you have some impact on your oral motor function. Was that an early sign for you, or was that something that evolved over time?
It evolved over time.
Right.
Like I said, you never know when the last time you write your name is. You never know when the last time you can speak is. You never know.
So you have to appreciate
Go
every
with
moment
the
that you're
flow.
going with. Yeah, you got
Yeah.
to go with the flow. So you have some alteration in your speech. Yes.
I went back to my neurologist, and they missed it because I'm too young.
Right.
You usually are 60 when you get it, but I was only 40.
How about swallowing? Do you have any problems with swallowing at all?
Yes, I do now.
So is that affect what you can choose in your diet, or does it mean that you just have to eat more slowly, or how does that work?
I like to say I eat slowly, but I eat very fast.
Anyway.
Because I always say, no one cares what you look like in the coffin.
Well, I'd say that's a pretty drastic statement, but I can't help but agree with it. Well, we don't really know that either. For that matter.
If you don't laugh, you're going to cry.
That's true. That's true.
Before Lillian's deep brain surgery, she had a very unemotional expression.
Right.
And a parent tries to do what he can for the child, and when you find no response, no appreciation, no smile, no warmth, something you may understand that is their problem, but it does affect you.
It really does.
But now that one of the great effects of deep brain surgery is that Lillian's face is so mobile. She shows her feelings, and it makes all the difference in the world in the relationship.
So obviously you two are her parents, and you've been caring for her through this whole process. And of course, that was a very impressive statement you just made, and we'll hear a little bit about that, but the loss of real expressive facial expressions is a big one. And as a parent or as a loved one, it must be very difficult to deal with the loss of expression because you get so much reinforcement, so much communication through those expressions. Tell us a little bit about how taking care of her has impacted your lives.
Well, when I retired and we discovered that Lillian had this illness, all of a sudden, it became a kind of vocation.
Sure.
To be involved. My wife is the primary caregiver, but there are so many things that you need supplemental help in. For example, it's a minor thing, but Lillian takes so many medications during the day, and I occupy myself with making sure that the supply is there, the prescriptions,
Sure.
and all the things, the mechanical things that are required.
So
but it helps you bear the problem.
So you've been there for her, which is a great thing, and I'm sure she's been very appreciative of that too. And then as time goes on, of course, you have your own issues to deal with. You're very fortunate to be healthy enough to be able to do that.
Yes,
we are.
Indeed. Maybe that's why we are spared.
Yeah. Well, it may be.
It's a full-time job.
Yeah.
I really, in a way, work harder now than I did when I was 30.
Well, it probably keeps you young then.
That's right. Absolutely. There was no time. A couple of years ago, I had breast cancer. I had no time for it. I just skidded over it, and I'm fine. I think that if I didn't have this full-time occupation, I would dwell more on it.
Lillian was a high-powered technical specialist, well-respected in a multinational company, and progressively she became unable to function in some of the more demanding areas. And there was, then finally, she could no longer work. And then in another year, she could no longer live in her own home. And then we took her into our house and tried to care for her. But one night I remember Lillian called out in pain in her sleep, and we rushed to her, and we were at wit's end to figure out what to do. Finally, we called the rescue squad. They came and took her out, and what happened then? Tell that.
I was in the ambulance with her, and all of a sudden she died. Her heart had stopped.
Yeah.
Oh, so you've been inside a coffin then. So you know what it looks like there, huh? I see. I see. Well, welcome back. I'm glad you're back. Yes.
I was watching her. Her eyes flickered, and she was gone. But the ambulance was manned by 4 women. And the woman who was sitting right there quickly just zapped her with and she just came right back. And when we arrived, we are 2 hours away from a hospital that we're going to, and halfway down.
Halfway there.
Halfway there, that happened.
Wow.
When I arrived at the hospital, the doctor told me, your daughter died, and this lady had saved her. And what it was, she had low potassium. Everybody was treating her for everything else, but nobody measured her potassium. It was like Shivo's case.
And was this from lack of nutritional intake, or was it from a medicine she was on?
Medicine, probably. I don't know. I'm not a doctor.
Anyway, I want to say this, that Parkinson's is a great teacher.
Yeah.
I wouldn't learn lessons I have to learn without having it.
So that's a very dramatic representation for sure. Most of you probably have done a lot of research to try to understand where this all comes from, and you're all bright, and you've all had your experiences with whatever professional or other kinds of endeavors you had growing up or becoming adults and working. But I wonder if anybody has done a lot of research to understand what the causes are. Are there any causes that you folks have a sense of?
Well, I wanted to add that
Yes.
I'm not a doctor, nor do I play one on TV, but I think that from my personal experience, no two Parkinson's patients are alike. The symptoms are always, you may have a series of symptoms that are similar, but there's always one symptom. You can have a room full of Parkinson's patients, and they're all different. It's fascinating. It's a fascinating disease. What I trace it back to is either chemical exposure mixed with well water, some sort of. I think there's definitely a environmental factor mixed with a genetic factor.
So you think you have a genetic predisposition that then is precipitated, or at least accelerated, or something like that,
yes,
by some environmental exposure. Any thoughts on what those are? I mean, there are ones that people have sort of put their finger on a little bit.
Well, I think when the FDA or when chemicals, we have 80 chemicals that are almost every year that are released into the environment. And when you have chemical composures of A plus B plus C, you have no idea what those chemicals mixed together do. So it's a hard thing to put your finger on what's. The more pollution we put in the water and the air,
right,
I think we're going to see more Parkinson's.
So it's more or less like a chemical roulette of some sort. So you have some thoughts. You've done some research.
I just happen to be an environmental scientist.
Well, that's a great place to have some perspective, sure.
So I guess the way it looks to me, first of all, there's a certain amount of Parkinson's that runs in families. And if you've got that, that's what it is. Most of it isn't. There are also a handful of chemicals that have been demonstrated to produce Parkinson's-like symptoms, such as manganese, 2 or 3 pesticides, blows to the head. But those don't amount to a whole lot of the burden of the disease either. There are some things that we do understand, or let me rephrase that. There are some things we know. I don't know if we understand them or not. It is fairly well demonstrated that people who smoke, who consume a lot of alcohol and a lot of caffeine, have lower rates of Parkinson's disease. And there are scientists out there who are analyzing cigarette smoke and trying to figure out what is it in there that protects against Parkinson's. My own theory is that if you have the kind of personality that tends to get addicted to things, then you have the kind of personality that doesn't get Parkinson's. Since addictions and thrill-seeking behavior and so forth are tied up with the dopamine system in the brain. Sure. So it's not hard to imagine that there are different sort of situations of the dopamine system that either do or don't lead to Parkinson's. But as far as environmental chemicals, other than these handful of pesticides, the studies, I think, in totality are very weak. There's a fair amount of evidence that something about rural life, well water, pesticides, or something that's correlated with those things, leads to higher rates of Parkinson's disease. But we have no idea what they are, and these kinds of studies don't separate one variable from a correlated variable very well. And so there are any number of ways that rural people differ from urban people, and it could be any one of them.
So we have primarily genetics, from what I've been able to deduce, that there's some tendency, and it would seem logical to me that the variations in symptoms reflect the number of neurons in the brain and the fact that different people probably have differential loss of neuron function. Tell us a little bit about what happens to the brain with Parkinson's and some of these types of problems.
Well, with Parkinson's disease, the cells that produce dopamine die off. And they die off slowly. In fact, but they die off more quickly than in normal aging. Everyone loses their dopamine-producing neurons as one ages. But with Parkinson's disease, they die off more quickly, and usually you need to lose 80 to 90% of the dopamine neurons before you actually start seeing significant Parkinson's symptoms. And what happens when that occurs is that when you lose dopamine, you lose the ability to have fluid movement. You develop rigidity, you stoop posture, walking difficulties. And some people, all the cells, it's the same neurons that are affected in each person. But interestingly, different people present different ways, and no one really understands why. Some people have tremor-dominant Parkinson's disease. 20% of Parkinson patients don't have any tremor at all, but they're very rigid and slow. So we really don't know what it is in the brain that causes those differences.
So, and you were mentioning that rural living, well, of course we think of rural living as in farmers, and there you have the herbicides and your pesticides and things of that nature in a much higher concentration probably. Is there an increased frequency in people who do farm or do those
Yes.
kinds of...
They've been shown, and usually every patient I see, I'll ask their background. Where
Right.
did they grow up? Where were they born? What type of work did they do? And invariably, in my own experience as well as in many published papers, it appears that people that grew up in a rural setting or living near a paper pulp mill or drank well water for a good part of their life seem to have a higher incidence of Parkinson's disease. But nobody knows for sure exactly what the cause is. But I think the most recent literature states that it's a combination of environmental factors in people that are predisposed genetically to developing Parkinson's. So it's a combination, and both of these factors work on the respiratory center of the cells and cause damage there, and they also cause abnormal protein accumulation in the cells, which cause cell death. So we sort of know what happens, but we don't know what triggers that per se. We think it's a combination of genetics and environment.
And what's the normal course of the evolution from the sort of, oh, I've got, gee, my hand is shaking a little bit, the tremors, to a more disabling state that...
It varies with every patient. I've had patients, and in this room, there are patients that have had the disease for almost 30 years.
Right.
I've had young onset patients, when I say young, I should say younger onset, in their 50s. And I've treated them now for 20 years, and it's just after 20 years that I'm starting to see in certain people some walking difficulties because their main symptoms were tremor before. I have other patients that I've treated for 5 to 10 years that are already developing side effects to the medication, walking difficulties, and it's a much faster course for whatever reason. We really don't know. So every patient is so different.
Right. Did any of you go through a period where you were in such denial you wouldn't tell your spouse, you wouldn't reveal to anyone you knew for fear of them talking to anybody that would say something that you thought might have some ill effect upon your career or your life otherwise? You had something else to say here. Yes.
First, on the statement about genetics and environment, I think that's true, but when you say environment, that doesn't mean pollution. That also includes birth order, family, social structures, diet, any number of things. Anything that's not genetic is environmental. A lot of people when they hear environmental think, nasty chemicals.
Right.
And that's not necessarily the case.
Sure.
In terms of telling people, there's no question I told my wife, where she saw it as it was developing. I have not told people in general at work. I'm still working half-time. But sort of if it comes up, I sort of tell them. So I just happened to have somebody comment that I was walking in a stooped manner, so I told that person. But I haven't sort of told everybody.
Right.
And most people don't know what to look for, and so they don't see anything. So I suspect most of the people at work either don't realize that I've got it, or they realize it but are too embarrassed to tell me. I'm not sure which.
And you wonder how many of them might have similar symptoms and wonder what's wrong with them as well. You were going to say something about...
My husband wouldn't tell his mother.
Oh, really?
For over 5 years.
Yeah.
And I knew about it from the beginning, and his family thought he had had a stroke because he didn't use his right side very much. And finally I said, you have to tell him or I have to tell him, but they're worried about you. And I talked about how people want to help and they want to be involved and they want to know what's happening because they love him. And finally he told them, but it took him a long time.
Yeah.
And for a long time he was worried about his working. He was working for the government and he was worried about how people would look on him.
Right.
And so that's a common thing.
So you would rather have them think you had a stroke?
Yes.
Yes. And you're comfortable with obviously with it a whole. Now, are your parents still around?
No.
So they were probably pretty accepting, no?
I think so.
Yeah. It was tough though. It's a tough thing. I can empathize completely. And you were...
I don't want to take up
That's
all
okay.
Time,
you're charming, and we love to hear what you have to say.
I'm really self-conscious of it.
Yeah.
And, people don't think about what I feel like, not eating right. or not doing anything right. But when a stranger comes up to me and opens the door, I feel like, what does they see about me that's so different? You know, they treat me different. Everyone's been very helpful at every level. You know, people open doors for me, and people open just their hearts, you know. But I'm self-conscious of it.
Yeah, I would imagine that's an easy way to be. The medicines are a very remarkable and important part of taking care of these people, of this condition. Was it really, when you started taking the medicine, you had symptoms, was it something that all of a sudden really impacted you? You said that that's how you realized you had the condition when you took the medicine and it worked, right?
Well, that was sort of the final diagnosis.
That was the final diagnosis.
By the doctor.
How about you? I mean,
Well,
have you responded well to medicine?
I have responded well to medicine. They started me on some drugs that when they diagnosed when they pre-diagnosed me with non-essential tremor, the drugs had no effect because I didn't have non-essential tremor. And when I was finally diagnosed with Parkinson's, they started me on Sinemet. I went from walking hunched over to walking erect almost within 24 hours. It was dramatic. And I was walking when I was early on. I was fascinating, where I would actually propel myself forward and not be able to walk, not be able to walk very securely. And then after taking Sinemet, within 24 hours, I was walking like a champ again. But one thing I did want to add was that one thing Parkinson's teaches you is you have to be happy in your own skin. I mean, you've got to you have to accept what you have to focus on what you can do and not what you can't do, and that's really what's one thing Parkinson's teaches you is that you know what you sort of know your place in the world. Right. And you have to be happy with it. You have to accept that, but also be able to strive for more.
Well, you could say you're as heroic as anyone could be to be able to find the silver lining in the clouds that came across your horizon. That's for sure. And it's a beautiful thing to see you be able to talk about it that way. So you've had inspiration. You've had a lot of support too, and I think that's where I see the greatest benefit coming for a lot of you. Now, so we have medicines that help to increase the lost neurotransmitter. We have some that do it in different ways, and I've read interesting things about them. Now, Sinemet and those kinds are one class. And then tell us a little bit about those medicines.
Well, we're fortunate to have so many different classes of medicines, and they all work on different areas of the brain. Sinemet is a precursor to dopamine, and it's transformed from L-dopa to dopamine in the brain. It's an active substance, and therefore you have more dopamine. We have some substances medications that we can add to Sinemet that will enhance more of the precursor levodopa to get into the brain, so we can prolong the effects of Sinemet. We have another group of medications that act as if they were dopamine, and they don't have to be transformed into they don't have to be transformed from levodopa to dopamine, but they latch directly onto the dopamine receptors and act as if they were dopamine, and that's like dopamine agonists.
Right.
Maripex, Requip, Permax, those are the brand names. And then you have a group of medications that are called MAOB inhibitors. And they basically block the enzyme that allows the dopamine in the brain to hang around longer because the enzyme isn't breaking down the dopamine. So we have all different...
It's interesting because I'm thinking back to what you were saying about individuals who drink and smoke and gamble and all those fun things tend not to be the victims or the people who get Parkinson's disease or any of those related.
That's actually, can I just
Is that not
clear that
true?
up? Yeah, there's a couple of, there have been some studies to show that caffeine and cigarette smoking can be protective, not alcohol.
Not alcohol.
Okay, not
Okay.
alcohol,
All
okay?
right.
So people that have a lot of dopamine, they tend to drink a lot or may have compulsive behaviors. But Parkinson patients, generally, most of my patients don't drink at all. They might have a glass of wine. But there have been several studies that show that caffeine and nicotine may have a protective benefit. I'm not saying that you should go out and start smoking.
Right.
And,
that's not the message we want to get across.
No, you
believe
definitely
me,
don't
right,
want to get
right,
that. And
no.
there's just been a new article out where somebody came up and said that the medications used to treat cholesterol may actually cause Parkinsonism. Well, that's one article. It doesn't mean that everybody in the world with heart disease and stroke and everything else should stop taking lower cholesterol medication. So you have to be very careful when you interpret these studies and not start doing bad things that are going to hurt you in the wrong way.
Right, and that was where the bad cholesterol went very low. But the media likes to grab on to these things, and they really, really magnify them just for the shock value so that you'll buy a paper and read the rest of the article somewhere buried in the A section or whatever it is. We know that, and it's going to be some time before we get enough perspective on it. It's interesting also that you're talking about dopamine, and as a pediatrician, I do a lot of ADHD care, and certainly some of those who aren't properly treated end up drinking and smoking and doing all those things as well. I don't know what percentage of them end up with the potential for the same kind of outcome with a Parkinson's syndrome. But I want, those medicines that you use to treat ADHD also, the stimulant meds, they increase dopamine in parts of the brain. Will they affect Parkinson's patients? Do you have Parkinson's patients who do take stimulant meds too?
Yes, but it's usually because they're having difficulty with alertness, often due to the disease itself or to the side effects of medication.
Okay.
And in some people that have a mild degree of dementia, sometimes that can increase their alertness, and that works out well for certain people.
Right.
I don't use it in a large number of people.
Okay. So, and some of these medicines will wear off. How about with the essential tremors? You've been taking medicine for how long?
I was 49 when I started it, so 20 years.
20 years, okay. And have you been on the same meds the whole time?
No.
No.
No. They seemed to wear off.
Right.
They started me out on, well, they're blood pressure medicine, a lot of it, and they started me out on a Telenol, 10 years, and then that didn't work. And then Dr. Sigmund switched me over to Enderol, and that worked for a while, and then it didn't work. And now we're on Myceline along with the Enderol, and it's working great.
Great.
So
that's good.
maybe I'm good for another 10 years.
Yeah, I hope so, yeah. I hope we can keep finding them. In 10 years should give you enough time to
find another
one to use, that's for sure. You just got to make sure you have Dr. Sigmund around to do that sort of thing for you. Yes, I'm sorry.
Yes, Dr. Sigmund, I have a brother who has Parkinson's, and he's down in Florida now, but he went through a period of time there, and this only goes back a couple of years, where he had the tremors set in. His gait was bad, but his gait was also affected because of his back. But years ago, he went into depression and was treated for depression. Now, this is before the Parkinson's. And then he had trouble with his thyroid. Well, all of this seemed, as according to the doctors, that he was seeing at that time, which was very difficult for us, the family, to understand, because unfortunately it wasn't a Parkinson-type doctor who specializes in it, and we felt, a little awkward, because it was called Parkinson-type syndrome for a while, which I still don't understand what that is, other than maybe it's a lot of medication. But what I was wondering is, just about a year ago, he had tremendous back problem, but he and his wife decided they were going to go onto a cruise. And he went on the cruise, had some of the shakes, as I called it at that time. Didn't have the same gait as what I'm normally seeing with some of the Parkinson's, but had a wonderful time. And everybody was real supportive on the trip, very close to everybody. And when they came back, he had completely a different perspective physically. Walked much better, attitude extremely alert, and no tremors at all. And I was just wondering, there's some relationship to that, or is there a possibility that when someone has Parkinson's, which they do say he has now, if that there comes a point where sometimes it suddenly stops and just stays in a stable position where it doesn't go up or down, even though he is being treated with medications of all sort. He has a great deal of medication.
Well, you know, it's interesting that you bring up what a wonderful time he had on the cruise. He may have been very depressed before he went on the cruise, and then when he wasn't depressed because he had such a wonderful time, he was feeling much better, and therefore he had less Parkinson's symptoms, because it's certainly, you know that the mind-body connection is very, very strong. So if you feel well mentally, then your physical features are going to be better. Same thing if you sleep adequately, you're going to have less Parkinson's symptoms, as you know, if you're well rested. So it could be that he had a very uplifting experience, and that had a positive effect on his physical symptoms. Your other point is that Parkinson patients can stay at a certain stage for years with minimal changes in their medication regimen. So it's not something that's rapidly progressive. If it is, then it probably is a Parkinsonian syndrome rather than true Parkinson's disease.
You know, we're running very quickly out of time, and I want to make sure that we are able to appreciate a work of art. Now, Lillian, you've had a lot of problems with your motor control, but you were able to do some art therapy and work.
I used the tremor to my advantage.
To your advantage. So we see a beautiful, and I want to get out of the way, we see a beautiful painting here that basically is the product of a good imagination, of a lot of focus and effort, and probably you have a new career burgeoning here. I do want to thank all of you for being here with us. It's been a really wonderful experience for me. And I want to thank our audience for tuning in. I'm sure that they gained a lot from this as well. And I want to thank Dr. Sigmund as well, and of course the crew and cast and whatever. Anyway, I hope you will join us the next time for here on Dr. Libby's World of Medicine. Until then, I'll be looking out for your health, so thank you. So.